Hello and welcome. My name's Alana Gordon. I'm a reporter at The World covering global health. This is a live Q&A about the coronavirus pandemic, surging cases, rapid diagnostics, and new vaccines. Lots to cover. And joining me is Dr. Megan Murray, the Rhonda Stryker and William Johnston Professor of Global Health at Harvard's Medical School and a professor in the Department of Epidemiology at Harvard's T.H. Chan School of Public Health. Megan, thank you for joining us.
Thank you for having me.
You can post your questions for us on Facebook at Forum HSPH, or you can email them to theforum@hsph.harvard.edu. And this Q&A is jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and the World from PRX and GBH. In this moment, we are experiencing both the amazing early signs that a vaccine is just around the corner. Scientists are close to developing even quicker and more widely available tests. It raises global questions about who will gain access and when. And at the same time, in places like the United States, coronavirus cases are surging like never before. To begin, Megan, I wanted to start with the current landscape of the pandemic. Just this past week, millions of Americans traveled over the Thanksgiving holiday. So how do you expect to see COVID-19 spreading in the aftermath of the holidays and what's to come?
Yeah, well, we were already seeing an increase in cases over the last couple of months, probably precipitated by people going back to school, to the weather changing so that people spend more time indoors, the opening of businesses that had been closed. And then on top of that, we saw this huge amount of travel last week. We really think that that is going to precipitate another surge. I think, as Dr. Fauci put it, a surge on a surge. So there already is a surge, but we expect that the amount of travel and the amount of mixing, especially between people of different age groups, so young people who've been at college or university and then came home to celebrate Thanksgiving, possibly with parents and grandparents, really that kind of mixing is what leads to these kinds of surges. So we're expecting that today might be the beginning of a surge. This is about 5 days out from, say, 5 or 6 days out from Thanksgiving. So if there were infections that took place then, they would start to become symptomatic around now. That will continue over the next few days. And then there'll be secondary and tertiary cases where the people who are infected who then affect someone else will continue to spread. And since we don't have the vaccine ready at this point, and we don't have any other new interventions other than the usual masks, we expect to see a rise in cases and a rise in deaths, unfortunately, over the next few weeks.
Are there, in this moment, policies, health infrastructure play an important role, of course, in preventing and also responding to infections, but are there best practices right now post-Thanksgiving for people and families thinking about reducing that spread?
Yeah, well, I think that what people really need to be cognizant of is that if they have attended a Thanksgiving event or, met with more people than they usually would have, that they could now be at huge risk. And so there's a couple of ways of dealing with that. One is to isolate until assume one's been exposed. And there certainly are states in which the rates are so high that if you met more than 10 people, then you can assume that you have been exposed. Or to be tested frequently. And that, of course, depends on being able to be tested frequently. But in this period, I would assume that one might be infectious until proven otherwise, if one has had an exposure over that 4-day period.
You mentioned, we're also in this moment of vaccines. And so, okay. There's a CDC advisory committee meeting today. We've been hearing, Moderna, Pfizer have applied, are waiting for FDA approval on emergency use of vaccines.
Yep.
The director of the CDC has said Americans could potentially get vaccinated just in a couple of weeks. And I wonder, how realistic is a timeline like that? What are you seeing as the reality of this, the challenges in the rollout?
Yeah, good question. So, I think that, surprisingly, it is realistic to assume that as soon as there is FDA approval, and by approval I mean emergency use authorization, that the rollout will happen. The government says that the next day, within 24 hours of an approval, there will be a distribution of vaccines. So they're set up to at least deliver some vaccine to some potential vaccinees, right? And really, what we're waiting for is the FDA process, which involves an independent panel that will meet and look at the data. The data is more than just the results of the clinical trials. It's also manufacturing data, the safety data, but once that happens, and that's a big responsibility, then I think that at least some people will be able to receive vaccine quickly. Uh, the actual timeline of the rollout depends both on the manufacturing, the speed of manufacturing, and then how we decide to distribute vaccine, um, and who decides how to distribute vaccine.
How do you think it should be distributed? And how is this, I know that there's an interest in healthcare workers, people who are older, essential workers. How do you see this being distributed?
Yeah, well, I think in reality, the decisions are going to be made at the state level. So state governments are going to have a lot to do with who in their states will get allocated the vaccine first. We're assuming that everybody will have access to the vaccine by, say, April, May, June. So it's a short-term question. It's not a sort of permanent thing, like who gets vaccine and who doesn't. It means who gets it first. And it really depends on what you're trying to accomplish. So if we're trying to interrupt all transmission, then we would aim for the people who are the quote, potential transmitters. So the people who have most social contacts that can't be avoided. So that's where people like healthcare workers who might see a lot of different patients and be in contact with people who are vulnerable are being prioritized. But if we're trying to minimize morbidity and mortality, so disease and death, now, then we would allocate it to the people who are most likely to get very sick and die, and that's the elderly, right? So they are much more likely to develop severe disease and die. So I think a strategy that kind of takes both of those things into consideration is going to be necessary. I think that we really do want to get the elderly vaccinated as quickly as possible. I think when we talk about healthcare workers, there's lots of different types of healthcare workers. Healthcare workers in many places are doing actually pretty well because they're quite used to using protective gear. Many hospitals have access to it, some don't. But the rates of infection in direct healthcare workers are lower than one would have expected. And that reflects really their attention to making sure that transmission doesn't happen. So it's a victory on the part of the healthcare workers. And that, of course, we would like them to be able to operate more easily. So getting vaccine will be very important. But healthcare workers that are working in nursing homes, and those are nurses' aides, anyone really in contact with the elderly in nursing homes, they have less access to protective gear, have less training in the use of protective gear, and they're at huge risk not only of being infected in the community and then transmitting that back to nursing homes, but both being often they are older people themselves or from vulnerable groups. So I think really targeting groups that are going to benefit both in terms of reducing their own risk of disease or death and then reducing further transmission is going to be crucial.
When you look globally at something like the rollout of a vaccine, whether it's the front runners appear to be, at least in the US, UK side, the Pfizer, the Moderna, there's also the Oxford AstraZeneca. What does this mean for access globally? Is there the infrastructure in place? I know that there are initiatives such as through the World Health Organization and Gavi and CEPI, these groups that really focus on distributing vaccines for other immunizations around the world. A lot of experts I've spoke to foresee and worry about the sort of inequality and unequal access to something like a vaccine, short-term and long-term. What are you seeing?
Yeah, I mean, it's a real concern, right? There are groups that have been thinking about this for a long time. You mentioned a couple of them. WHO, Gavi, and CEPI have actually joined forces in a consortium called COVAX. So, and their mission is really to make sure that they negotiate with the companies making the vaccines so that they can get access and then distribute them and then pay for vaccine for countries that can't afford it themselves. I mean, this is it's a huge problem that has existed forever. The access to pharmaceuticals that are expensive to make and expensive to buy for the countries that need them the most. What's interesting right now is that it's not always the poorest countries that have the highest COVID rates. So we will really need to come up with a strategy to make sure that there is equitable distribution. Um, but in the short term, I think that the countries that have the highest rates are some of the ones that probably need it the most.
Like the United States.
Yeah, surprisingly, yes. I mean, it's not usually the country that has the highest incidence of any infectious disease, but at the moment it does, or at least it's one of them.
Are you seeing in those efforts any progress or any delays, for example? Or is it just kind of the priority has then been going to some of the places that both can afford the vaccines, but also maybe are completely in it themselves when it comes to surges?
Yeah, well, the biggest sort of obvious obstacle is infrastructure. The Pfizer vaccine needs to be kept at 94 degrees, negative 94 degrees Fahrenheit. So that's not easy to achieve, right? You need, and in fact, there's many rural parts of the U.S. that don't have hospitals or healthcare facilities that have access to a freezer that can store a vaccine at that temperature. So it's not just a global health issue; it's also a domestic health issue. But not all vaccines are going to require that. So even the Moderna vaccine has, which is also an mRNA vaccine, very similar to the Pfizer, but doesn't have as stringent requirements for a cold chain. Um, so that's good. And then some of the other vaccines that use different approaches, particularly the Johnson vaccine, probably will not need any kind of extreme temperature management. So there are a lot of different companies and groups making vaccines, and they're fortunately for us, there's a lot of variety in the kinds of vaccines that are going to be made. Um, that's good and bad. It means that we have to trial all of these, and that's a lot of vaccine trials to get to the question of whether these vaccines work. But if they all do work, then we'll have a lot of room to move in terms of putting the right vaccine in the right place. It's not easy, but it's doable. I think one of the most encouraging pieces of historical input is that the Ebola vaccine also needed to have very stringent temperature controls. And people were able to use it in parts of Africa that they didn't think it would be easy to keep vaccines refrigerated because they could develop these units that could be shipped in that had the capacity to have really cold storage and in provisional facilities. So, I think one of the things we've learned from the vaccine effort is that when people set their mind to doing things, they can actually get them done.
That's hopeful.
Yeah, it's encouraging.
This question comes from Lexi. What type of side effects should people prepare for after receiving a COVID vaccine? And I'm going to, guess that this question's directed at the ones that are currently most quickly in the pipeline, like the Moderna and the Pfizer.
Yeah. So the reports from Moderna and Pfizer are that there's a normal, when I say normal, risk of immediate adverse events. I mean normal in comparison to things like flu vaccine. So like other vaccines for common infections, people can expect to get a low-grade fever, have a headache, usually for only 24 to 48 hours, and then that passes. So those are really evidence that there's an immune effect from the vaccine. The vaccine has been rolled out in really large studies already, right? So 30,000 people in some, even more in others. And so we do have the opportunity to look at the frequency of side effects, and they're remarkably low, and again, similar to other vaccines. We don't have the longer term experience, right? Given the way these vaccines work, we don't really expect there to be surprising long-term adverse events that show up, say, months or years later. But we really only have 2 or 3 months of trial experience, and that's all we could go with for the time being.
I wanted to ask about testing because that's another area of that plays so much into as a part of the pandemic when it comes to prevention and also awareness. Last month the FDA authorized an at-home rapid coronavirus test. It's a nasal swab that you can do yourself and get results in about 30 minutes. Do you anticipate that something like this could be a game changer for diagnosing and controlling the spread of COVID-19?
Well, I think using the term something like this, yeah. So the Lucira test that came out a couple of weeks ago is a really interesting test because it's not a antigen test, which just is so just looks at for the proteins that the virus causes. It's actually a nucleic acid amplification test. So it's a really high sensitivity specificity test, similar to getting a PCR in a lab. Not quite as good, but it depends on how one does the sampling. But it's a very good test. It costs about $50, so that's relatively inexpensive when you sort of think about tests. But if what your goal is to test frequently, say every couple of days to make sure that you don't have infection before you mix with other people, then that's going to quickly add up. And the other thing is at the moment, the FDA approved it with a physician's prescription. So I think the likelihood that it's going to be used as a very high throughput screening test where people can test themselves at home without having to tell anybody what the results are, but then acting if they find out that they are positive. That still remains. I mean, it's certainly doable. There are rapid tests that are like pregnancy tests that you can just do at home. They haven't been approved by the FDA so far. And part of the reason is that the FDA is using the criteria of high sensitivity and specificity to approve the test. So there's something of a debate about whether that's really what we're looking for in a screening test, or whether having a less perfect test that could be used cheaply and more often would be a really useful tool in the armamentarium for prevention as opposed to, say, diagnostics.
What about when you look globally in other parts of the world? For example, there's a lot of communities that don't have access to the labs to do the testing. How available are these other kinds of rapid tests, even with in a clinic or something? I mean, has that changed?
Yeah, well, surprisingly, in some countries, they were available long before these tests were available back in March and April, right? So in Korea and where a lot of other Asian countries, they've been available for a while. They have not all been approved. Every country does its own approval process. So while rapid diagnostics could be available, depending on how you use them, they are only being used in research settings in many places. Again, it comes down to what you're asking from a test. Are you asking for it to be used as the only diagnostic in a hospital setting to really know whether the person has COVID or not? Or are you using it as a way to possibly screen for COVID to keep people who might have COVID from mixing and then go get another test? There are the possibility for cheap tests that can be used at point of care or even at home is there, and we really have to come up with a strategy for how best to make use of them.
For example, I'm thinking of like a a couple months ago, the WHO with some groups launched a big effort to get rapid tests to more places around the world, some over 100 million tests. And I wonder how well that's working and if it's soon enough.
Well, they are it's not hard to get the test, but what is more challenging is to be able to use it in particular countries that don't, because you have to have approval to use it. And so one can order tests from the manufacturer, but once they come to many different countries, probably most of them, then they can't yet be put into sort of routine clinical use because they're not approved, as they aren't in the really rapid. There are some tests that are approved in the U.S., rapid tests that can be used at the clinic level. At the home level, there's really only this. Only Lucira allows you to get a result at home. There's a number of tests that allow you to do the swab at home and then send it in. But I think the obstacle here is not getting the tests or even getting cheap tests. It's getting through all these approval processes and then knowing how to make the best use of these tests once you have them.
Globally, so even like if the WHO approves a test, you're saying?
Yeah, they have to approve the test for a particular indication, and that they need to be clear about whether that indication is, this is the only tool you have available to diagnose COVID, which would be, and these are not perfect tests, so you would miss people, you would overdiagnose and underdiagnose people, or whether you're using these as a prevention strategy that involves screening.
So there's several questions that have come in from online, kind of piggybacking off of this testing question. One is from Anne. Why is there still such disparity in the COVID testing realm in terms of who can get a test easily, how long results take, why some schools have mass testing and others don't?
It's a great question. I mean, it's chaos, really. Even in particular towns, like I live in Cambridge, and we had two teenagers who were trying to get tested. One spent a day waiting in a line, got sent home, got called back. The other one got a test immediately. So it depends where you go, and if you set up an appointment. If you ask in Cambridge, when can you get the next appointment? They tell you it's in the middle of January. If you show up, they might do the test. So, I mean, I think what it reflects is the lack of oversight of strategy, of how, who's in charge of distributing tests, who's in charge of coming up with a policy for how they can best be used, and who's in charge of getting them to the places that they need to be. And really, what we've seen is that there's widespread chaos around this, and it does show that we need to rethink our public health, governance, because in the U.S. we haven't been able to put a reasonable strategy into place that ensures equitable and quick testing, but many other countries have, especially the countries that responded early in the epidemic in Asia. So it can be done. It just hasn't been done.
This question comes from Patrick. Does the United States actually have the most cases in the world, or is it evidence of higher testing capacity, even in that chaos?
I don't believe it has the actual highest number of cases, right? I mean, if you're talking about total or daily, I'm not sure, but it has a very high number. I mean, it's up there with other countries that are at the top of the list. And it does not reflect the capacity for testing. There are definitely countries that are underestimating the number of cases they have because they don't have access to testing. But there's many countries in the world that actually do as much testing or more testing than we do. Now, I'm talking about the percentage of the population. So when you hear we have tested more people than any other country, it's a big country, right? So I work in Rwanda, which has done per capita far more testing than the U.S. has done. But of course, it's a small country. So if you actually look at the total numbers, then the U.S. has tested more people. But if this is a place where it's been really surprising I think, to many to see how effective public health work in many countries that people consider impoverished has been. And the we are not doing well in terms of testing per capita, and testing not only per capita, but testing in terms of the amount of COVID we're seeing. So there's still states right now where the probability that one will test positive is almost 50%. That's usually a reflection of not getting enough testing. If you expand testing, that percentage should go way down.
So it's almost like the opposite is what you're saying.
Yeah.
Um, this question's from another one from Anne. Is there a need for deep posterior nasal swabbing?
The painful part. Probably not. If you do the mid nares or anterior, people are comparing, the results of tests from deep swabbing to less deep swabbing, and it's qualitative. So there's some differences between getting a better sample, but probably not enough to warrant the kind of fear and dread that people have of having, a nasopharyngeal swab put back, deeply in that area. It's really, it's I wouldn't say it's painful, but it's not pleasant, and people it discourages people from getting tested when they should be tested more often.
This question's from Bill, and it's going back to the question themes of there's several questions that have come in about vaccines.
Yeah.
How will the number of Americans who may be hesitant and refuse to get vaccinated, how might that impact the level of COVID-19 circulating?
Yeah, well, it depends how many there are, right? So the idea of the vaccine is to get to herd immunity, right? To get a certain proportion of the population vaccinated, so that when one is circulating in the community, that the person that you run into is likely to be immune and not infect you. So even if you haven't been infected or vaccinated. So, if half of the people in the country refuse a vaccine, it will be really challenging to get to herd immunity without transmission of the organism itself, and which we don't want to see, because there's a morbidity and mortality cost to being infected with the actual virus. So it is a real problem. I think people are nervous because of the speed at which all this has happened. I have to say I'm really impressed. I'm usually a cynic, and tend to be suspicious of rapid processes, but I think the trials have been really well done, and they've been well monitored, so that I think that as people learn more about the vaccines, and as they see them rolled out, and as more time goes on, I'm hoping people will be more enthusiastic about uptake. But there will be pockets of, we've seen this with other vaccines, that pockets where whole communities just don't want to get vaccinated, and those communities will still be at risk.
Given your, optimism with these vaccines, this question comes from Jack, which is, how long did some of these phase 3 trials last? Is that really long enough to observe participants and the effects of the vaccine? Is there any reason to wonder if the preventive effect seen in the short period will last if they're observed for a longer period of time?
Yeah, we don't know how long these vaccines are going to last. And it might be challenging to find out, because the trials were done in periods where there was a lot of transmission. So that's one of the reasons they could be so quick, is the incidence was high and they were very big trials. But as time goes on, and we assume that the vaccine will have an impact on lowering incidence, then we won't know whether people, later, whether people are not getting infected because they're protected by the vaccine, or not being infected because there's nobody around to infect them, who still is infectious. So ideally, in the ideal world, if we were all robots and we weren't humans, we would want to leave people who were on placebo, so people who didn't get the vaccine. We want to observe them for years to see what the impact is. But no one's going to say to somebody who was a volunteer to be in a vaccine trial, no, you can't have the real vaccine because we need to observe you. That would make no sense from an ethical perspective. So it's going to be hard to know how effective they are. We will monitor things like immune responses as opposed to disease itself. So people who got the vaccine will be followed for extended periods to see if the immune response, as measured by antibodies and serological responses and T cell responses, if that wanes over time. But whether we will lose whatever efficacy we have against actual infection and disease will be hard to know exactly when that happens.
We just have a few minutes left, so I wanted to get to some other non-vaccine related questions.
Sure.
Are there any updates about why some people seem to get sicker than others beyond something like advanced age or a pre-existing health issue? Are we learning more about what might be involved in that, whether it's genetics or other factors?
Yeah, I mean, we're learning so much that it's hard to actually sort out which are the main contributors. So I think it's increasingly clear that there is a potential genetic signal, especially if you look at people who are completely unaffected, and the people who are really sick. But the genetics it's not just like a question: do you have this gene and not gene? If you have that gene, you're going to get sick. What those genes do is what we need to learn, right? So we know that people who have this florid immune response are the people who do badly. But and we know that there are certain risk factors that make that more likely, right? And we increasingly know the immunologists have really
factors also like being the type of work that you do, or maybe the housing situations, but also the other health issues.
Well, so there's two pieces there, like the risk of being infected and then the risk of having bad disease. So we tend to separate those out. The risk of being infected really does depend on the work you do. The risk that one is infected and has evidence of infection is probably less determined by risk factors and more just by who you're mixing with and whether you go to Thanksgiving with 20 people or two. But the risk of having bad disease if you get infected does seem to be very much a function of a series of individual risk factors. And most of the basic science and the around that's happening right now is about what aspects of those risk factors. Why do people with, say, heart disease get sicker? I mean, there's no obvious connection, but then you need to backtrack and see whether the factors that lead to heart disease also are somehow associated with COVID morbidity. Age is a huge one, and it really is. We don't exactly understand why age so reliably predicts morbidity and mortality.
We're just wrapping up. I wanted to get to one more question from online, and then one question that I have. And this is about back to testing. This question is about how, some colleges, some workplaces are doing regular asymptomatic testing to control the spread of COVID-19, but it doesn't seem like there's a lot of uniformity across institutions. Some are testing multiple times a week, some not at all. Is there any evidence emerging on like optimal testing strategies and best practices?
No, I mean, not in terms of actual data analysis, because there aren't, at least as far as I know, there aren't systematic studies that say, let's try, this regimen versus that regimen. But I do think that the modeling can contribute to this, to kind of coming up with at least ideas about what the optimal frequency of testing would be. And the problem here is that different populations are doing very different things. So if you're testing students who are mixing in particular ways, that's one thing. If you're testing people who are healthcare workers who are in maybe much more contact with people who are likely to be sick, that's another thing. So we're going to end up with different strategies for different groups. All of this depends on having cheap, FDA-approved tests that can be done quickly and preferably at home, so that people don't have to go out and wait in lines to do this. And so there really are limited settings in which this is happening. Some universities, sports teams, it's ironic. I mean, where it probably should be happening is in nursing homes. But it would be nice to see an alignment between where they're most needed and where they're available. That hasn't really happened yet.
Just one more question, kind of a concluding question, which is just that we didn't get to. A lot of your research is focused on tuberculosis, and even anti-tuberculosis vaccine called BCG that you've been looking into potential protectiveness against COVID-19. And so I wanted to just wrap up and ask, what do you see as similarities between TB and COVID-19? And are there, some big lessons to be learned and that can be applied when you think about containing TB and looking at the current pandemic?
Well, so let me mention BCG. BCG is a vaccine that was developed for TB. It's actually a live attenuated form of a mycobacteria that has been in use since the 1920s. And most people in the world get it at birth. The US has never used it. Certain countries in Europe have never used it. But one of the really interesting things about it is that it seems to protect people not only from TB, but also from other infections, and a wide range of infections, including other respiratory viral infections. So my team and then lots of other people throughout the world speculated early on that BCG might be protective against COVID-19. And there are a number of clinical trials that are ongoing throughout the world, several in the US, a number in Europe, India, South America. And so we'll have an answer to that question at some point. TB is really, it's a bacteria. It's quite different from COVID. One of the things that's similar about it is just the huge numbers of people affected. So until COVID came along, TB was a single infectious disease that killed the most people in the world. And the numbers are astronomical, but it's extremely neglected. So when you think about, how much attention has gone to COVID, how much we've been able to accomplish developing these vaccines that have been hugely successful in this short period of time, it puts the TB question into even sort of sharper perspective. That TB has been the disease that has killed the most people in the 20th century, 1 billion people probably. And we still don't have effective tools that are readily available and distributed. So to me, it's a story about what happens when rich countries have problems and how easily they can be solved. I mean, no one thinks solving COVID has been easy, but in comparison, and how diseases get neglected if the people who get them are not living in rich countries, are not the rich people living in rich countries. So it's a story about poverty, and it's I'm hoping that the world will take the lesson from this, that problems can be solved, and that we need to put our minds to it. But the TB problem is one that will remain after we've solved COVID, and it really needs the kind of attention that we've seen to COVID.
I think that's a really important note to end on. Thank you for running a little bit over with our conversation.
Sure.
So that concludes this discussion. And this Q&A has been jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and the World from PRX and GBH. You can view the full conversation on our Facebook pages and send feedback at Forum HSPH and at PRI The World. And join us again on December 15th at noon Eastern Time for a discussion about the latest news on the pandemic with epidemiologist Michael Mina. I want to wish everyone a very happy and healthy holiday season.